So to introduce myself, I'm Rachel Cooper. I am a consultant clinical oncologist in Leeds, specialising in gynae and GI cancer. I have had many hats on at the college, including a TPD, head of training, very much involved with the college as a trainee, sitting on what was the equivalent of the ORF then, but a different name when I was a trainee. Many of you will know that I've been involved in the first FRCR, both as an examiner and chair of that board. And now I was elected as Medical Director of Education and Training, and therefore I'm the person responsible for looking after your training for the next 3 years, which is a great honour. In addition, we have Louise Leon Andrews, who will speak after me, and she is our training, quality and curriculum officer, and we work extremely closely with Louise, and she has been, I would say, the driving force behind making sure that we do implement a new curriculum, and has kept us very much on the straight and narrow with her huge amount of enthusiasm and knowledge, and is somebody who can answer most of your questions with regards to the new curriculum. And then finally, we have Graham Lumsden, who is our excellent chair of the curriculum committee. And he's been helping us and guiding us through, again, implementation of the new curriculum. And just finally, and there's Graham, he's appeared finally. And then just before we do move on to the main sort of body of the talk, I want to acknowledge Frances Ewell, who was my predecessor, the previous Medical Director of Education and Training, who put a huge amount of time and effort into developing the curriculum, working very, very closely with the medical oncologists, particularly Jackie Newby, and they did really put a lot of work and effort into this. So I'm really kind of taking over when most of the really hard, heavy lifting work has been done. Okay, so if we can move on, Louise. And the reason we're here is because of the change in requirements with regards to the curriculum that the GMC have introduced. And some of you will be aware of some of the documents and papers that have been produced around curriculum and curriculi. So the new Excellence by Design, the standards that are required of all postgraduate medical curricula, asking them to be rewritten and based on very high level outcomes. And at the same time, these should be linked to the GMC's generic professional capabilities framework. And it also requires that all curricula demonstrate how they meet the recommendations of Shape of Training report. Now, the Shape of Training report, you may remember the core aspects of this was that with an aging population, we need to think about the holistic management of the individual rather than super specialized management of each specific medical condition, which is the way that things had been going. And this therefore requires a resetting of the balance between specialism and generalism. So we recognize that there still needs to be some specialism, but we do also need to think about the patient in a holistic way. And I think many of you will recognize that most of our patients come with comorbidities and other problems relating to their social situation. So the Shape of Training report also recognised that there was a huge and increasing acute unscheduled care burden, which was mainly coming through acute medicine. And this was not being well supported by the current system. So for trainees, flexibility of training was also recognised to be lacking in the current system, and therefore there was pressure on us to look at how we were able to adapt to that flexibility as well as changing service needs over an individual's career. The GMC approvals process now begins with an initial review of the curriculum by the Curriculum Oversight Group, or known as COG, and that mostly consists of members of the UK Shape of Training Steering Group. So there's that sort of link back to that group, and solutions and challenges. It challenges the solutions that we've come up with, and they ensure that the recommendations of Shape of Training are integrated into the curricula. Separate to these issues, the current curriculum that most of you will be aware of, we recognise is long, it's repetitive, and it's not really a very user-friendly document. It's also based on outdated educational practice, And when we've asked trainees and trainers, they report that they rarely use it. Okay, so we move on to the next slide, please, Louise. So we're going to use some polls throughout tonight, and this is the first one. And the poll is open, so I would like you to look. Have you been involved in any local discussions about implementing the new curriculum? And I'd be grateful if you could select on your screen one of those 4 choices. So I can see that lots of you are voting. So I can see that the majority of you, I would say, are not aware of discussions taking place, or aware of discussions but you've not been invited to them, with a really small minority, less than 10%, know that discussions have taken place or have been invited but unable to attend. So that is quite concerning in a way, and that shows that the sorts of initiatives such as tonight are very important, that we're able to share this new curriculum with you, because obviously this curriculum is about you and is going to influence your training, because this is not just for new trainees. All trainees will migrate onto this new curriculum. So I think it's really important that we impart as much information to you tonight, and you have as much time, you have the ability to ask as many questions as you'd like to. So if we think about what are the key changes in the new curriculum. So the clinical oncology curriculum was worked, the curriculum committee rather has worked really closely with Medical Oncology Specialist Advisory Committee, that's known as SAC, to align the 2 curricula. And we were challenged by the Curriculum Oversight Group at the GMC to improve flexibility for trainees by recognising common areas of training, and to provide greater support for the acute unselected take, acute oncology. And the reason for that was that it would equip trainees to manage and develop skills in acute oncology. So this is not just about being on call, this is about acute oncology, as increasingly we are recognising it, with the ability to better manage those patients and also take some of the burden from the acute unselected take. The new curriculum certainly reflects those requirements, and COG has recognised that as well. So we'll look at each of these changes in a bit more detail on the following slides. So the next slide, please, Louise. So first of all, what's not changing? Well, the entry requirements will not change. Full MRCP is required for entry into both specialties, as it is now, and trainees must have completed at least 2 years of internal medicine stage 1 curriculum, and that replaces CMT, or for overseas trainees, the equivalent of that. We know that some trainees will have completed 3 years of internal medicine stage 1 and 2 curricula, the 3rd year being the medical registrar equivalent year, and they can also apply. That doesn't disadvantage anybody, and they will of course have had that additional experience. The recruitment process is unchanged, although you will be aware that as currently, because of the pandemic, all recruitment will be done as a virtual recruitment, but we are still intending, and I have no reason to believe this will not happen, that we will have some form of face-to-face interview, albeit on a platform such as the one today. And clinical oncology is in a good position, because we've already rehearsed that, having done that for our 2nd round recruitment towards the end of last year, very successfully as well. The exam structure for both clinical oncology and medical oncology will remain unchanged, although obviously at the moment things are a little bit up in the air. And separate to this work, the exam syllabus is being reviewed with the aim of making the content, particularly for things such as the statistics module, much more clinically relevant. There are no changes to the tumour type requirements for each specialty. Okay, thank you, Louise. So just to summarise that in a sort of visual way, doctors will come after they've completed medical school, they'll come into training, complete their 2 foundation years. There will obviously be the selection process into internal medicine, and they will complete their minimum 2 years of internal medicine. But as I said, if they do the 3rd year, that won't disadvantage them. They'll complete MRCP, and then there will be the selection process into oncology. The ST3 year will be the oncology common STEM year, where the curricula will be aligned between medical and clinical oncology. At the end of that year, trainees will need to have had a satisfactory ARCP. And of note, the ARCP grids at the end of ST3 are the same, irrespective of the specialty. And assuming a satisfactory ARCP, they will then pass on into either clinical oncology specialty training or medical oncology specialty training. And there will be no difference in the length of those training. So a further 4 years for clinical oncology and a further 3 years minimum for medical oncology. So the overall minimum lengths of training will not change, although we recognise, as it is at the moment, there will be a variability in that length of training depending on the trainee's personal circumstances, or if they choose to do additional training such as UPAR or UP. So I'm now going to hand you over to Louise, who's going to give you a little bit more detail about the curriculum structure.
Thank you. So the curriculum is structured around a smaller number of high-level learning outcomes. So you'll be familiar with the current curriculum where there is an incredibly large list of competencies. So we've got a much reduced number of high-level learning outcomes in this curriculum. And these are exit outcomes. So they describe what a trainee should be able to do on CCT. And the outcomes have been called capabilities in practice to same terminology that's used in the new internal medicine curriculum, and also what's being used in medical oncology as well. And the CiPs have been divided into 3 groups. So the generic CiPs are those that describe the outcomes expected of all doctors, things like good communication and team working skills. There are 6 of those, and they are identical in the medical oncology curriculum as well. We then have shared oncology CiPs, which describe the outcomes that apply to both CO and MO trainees. And there are 7 of those. And then the CO curriculum and the MO curriculum also have some specialty specific CiPs. So we have our clinical oncology specific CiPs, of which there are 6. So each CiP within the curriculum has a table that looks a little bit like this. So I've used one of the CO specific ones as an example here. So the CiP is in the top section of that table, and then each CiP has some descriptors that provide a breakdown of the underlying skills for each CiP and give some guidance to trainees and trainers about the range of clinical contexts that can support achievement of the CiPs. They're not expected to be an exhaustive list or to be prescriptive. They're there to provide guidance. Underneath that, there's some suggested evidence that trainees could provide to show that they have achieved those CiPs. And again, this is suggested evidence. It's not a full list. There might be other ways that trainees have demonstrated that they have made progress against these CiPs. And it doesn't necessarily act as a checklist where all of those things have to be linked to each of those CiPs. Each CiP is also mapped to the GMC's generic professional capabilities. And this is a requirement for all of the curricula, so this was something that the GMC said that we had to include. When it comes to assessing the CiPs, we've tried to structure it to hopefully streamline the assessment process. So by assessing the trainees' progress against one CiP and making a judgment about whether they can be trusted to perform that CiP independently, we automatically assess the underlying skills that will allow them to perform that task independently. So if a supervisor judges that they are entrusted to perform that particular CiP independently without supervision, then they must have also achieved the underlying skills. If the trainee is not yet capable of performing the task described by the CiP independently, then you can start breaking it down into the descriptors and identifying which of the descriptors still requires progress. So it helps trainees and trainers to target further learning and to set targets and support trainees. So in terms of how the assessment will take place, we have entrustment scales which will be used to assess each of the CiPs. So level 1 on the entrustment scale would be that the trainee is entrusted to observe only, with no direct provision of clinical care. Level 2, they're entrusted to act with direct supervision, and that means that the supervising doctor is physically present at the site of patient care and would be immediately available to provide supervision. Level 3 is that they're entrusted to act with indirect or minimal supervision. So the supervising doctor doesn't necessarily have to be physically present within the hospital at that stage, but would be available by means of telephone or other media to provide advice and could attend physically if they were required to. And then level 4 is that the trainee is entrusted to act unsupervised. So they're working independently in a level equivalent to consultant. The key question that the supervisors will be asking themselves when assessing trainees is what level of supervision you, the trainee, would require in the area of practice being described by that CiP. So as you progress through training, we'd expect you're starting off at a lower level of entrustment and progressing to the higher levels. And we have progression grids within the curriculum that set out the expectations for each CiP at each level of training. So here we've got one of the progression grids which shows the clinical oncology specific CiPs. The column for the ST3 oncology common STEM year is shaded out in this one. We've got a separate grid showing that which matches up with the medical oncology curriculum. But it shows for the top CiP, for example, CiP 14 progressing from ST4 at a level 2, so entrusted to act with direct supervision. But then by the end of ST5, we'd expect that the trainee would be able to act with indirect supervision, and then by the end of ST7 that they'd be able to act unsupervised. It's important to note that these are minimum levels of entrustment to be achieved by the end of that stage of training. So trainees might progress at different rates in different CiPs. So they may be above expectations or above the minimum requirement in some CiPs. And an important thing to note as well is that the CO curriculum doesn't require all trainees to be at level 4 for all of the CiPs by the end of training. So you notice on this particular progression grid that the last 3 CiPs, trainees are only expected to be acting with minimal supervision still. So as an example, CiP 18 relates to the delivery of brachytherapy, and trainees are not expected to be fully independent in this by CCT and wouldn't be acting independently in that area of practice even as day 1 consultants. So the level was set at level 3. Another important note when looking at the progression grids is that the expected level of entrustment applies to the whole CiP. Not necessarily to each of the constituent descriptors. At first sight, some of the levels might appear to be set with relatively low expectations, but if you look at the detail of the CiP, you'll find that's actually not the case. So CiP 8 is a really good example of that. This is the CiP that relates to acute oncology. So it talks about delivering the acute oncology take, managing oncological emergencies, providing oncology advice, and managing the AOS team. So glancing at that quickly, it would be easy to think that trainees would need to be independent in that very, very early on in training. So as an example, most trainees would be managing oncological emergencies independently. But this CiP also covers managing the AOS team, which is a more complex level of practice. So the overall level expected is not level 4 until the end of training. So I'm going to hand over to Graham now. Oh no, sorry, there's a poll question first. Bear with me just a second. So our poll question here, do you think that you'll find the entrustment scales easy to understand? I appreciate it's the first time that many of you have seen those. So vast majority think that they are easy to understand, which is good. That's what we were aiming for when we were designing them. And the medical oncology curriculum uses a very similar system of entrustment as well. So slightly different spin on that question. Do you think your supervisors will find the entrustment scales easy to use and understand? So still the majority of people think yes, but slightly less so in terms of the supervisors compared to the trainees, which is interesting.
I think that also tells us, Louise, that we need to do some education in that area.
Yeah, absolutely.
That's really
Okay,
interesting.
I'm going to hand over to Graham now to talk a little bit about the oncology common STEM year.
Hello there. Thanks very much, Louise. Thanks very much, Rachel, as well. The next few slides are going to cover the Oncology Common STEM year, what it entails, the decision aids, progression grids, a bit about acute oncology, and about the workplace assessments and some of the changes that are being made to those assessments. Do you want to do that just now, Louise?
We had intended to, but I think actually the question earlier about the whether trainees had much training on this
All right.
probably covers it, but we're getting some responses in, so I'll just give it a second and share the responses so far.
Okay, so 18% understand, 67%, 2/3 have heard of it but don't fully understand, and 16% have never heard of it. So hopefully by the end of these next 5 or 6 slides, it will become absolutely crystal clear to you all. But clearly, I think from the first poll, that I think we still need to clearly do a lot of work amongst our local teams and try to get the information out about the new curriculum, and especially about the Oncology Common STEM year as well. So, the Oncology Common STEM year will be the common SD3 year for both medical and clinical oncology trainees, as Rachel already said. Recruitment will still be through national process in both medical and clinical oncology. Trainees will still have their standard ST3 number, and will enter into their respective specialties. Clinical and medical oncology trainees will achieve the same outcomes to the same level by the end of the ST3 year. This ST3 year, oh, sorry. Includes exposure to acute oncology. Essentially, the medical oncologists will have to do some more radiotherapy planning. The same amount of exposure to anti-cancer therapies will be needed. And from a clinical oncology point of view, it's felt more that there may be some more exposure to clinical trials, although to what level is maybe variable around the country. The focus of this acute oncology STEM year is on the development of the generic and the common oncology CiPs. So those are the first two categories of CiPs. There is no specialty specific CiPs in the oncology common STEM year. We feel that the oncology common STEM year meets the shape of training requirements. It supports generalist training principles and allows greater flexibility so that if a trainee does want to switch, that there will be that whole year taken into account. Okay, next slide, please. So the flexibility from the oncology common STEM year, following completion of the OCS at the ARC-P, trainees will progress into ST4 and will then continue on their training either in medical oncology for another 3 years or in clinical oncology for another 4 years. The individual entry points for both specialties remain the same. The transfer between specialties at present has to go back through national recruitment. So if you're in an ST3 in clinical oncology and after your oncology common STEM year decide you want to do medical oncology, you'll have to go back through national recruitment. The trainees are obviously able to do this at the present time, but the ability to count all the training is very variable. As I said earlier, both specialties has been agreed through the GMC that the whole year will account for that. Some people have asked before, what if I want to change at ST4? Well, that may involve some extra training time, but you will still have the whole year of your oncology common STEM year counted towards your training. Next slide, please. So this is the ARC-P decision aid for the oncology common STEM year, which shows you the assessments that need to be carried out. Now, for us in clinical oncology, there are a few new assessments, and there are a few new assessments for the medical oncologists as well. The single MSF is the same. There are 2 mini CICs, 2 CBDs, one including a patient on a clinical trial, and that can be anything related to the clinical trial, 2 DORPs and 2 DOSTs, 1 ACAT, which is new for us, which is obviously focusing on the acute oncology side of training. It's obviously new for ourselves as oncologists. I understand that lots of trainees who have come through core training will do these already in the acute setting. This is simply the ability to try to capture the experience in acute oncology, in the acute oncology setting. What's also new is a multiple consultant report, which again is used in core training or IMT training, but it's new for us in clinical oncology. We are still in the process of kind of finalising these through the curriculum committee. This is a report of a summary of 4 to 6 consultants, which should include 1 each of the other specialty, be that medical or clinical oncology consultants, and should give a greater breadth of consultant views on patients' ability through the oncology common STEM year. We need to show portfolio evidence of MDT participation with a valid GCP certificate and with educational supervisor's report, a structured report for the year of training as well. Next slide, please. So Louise had shown you previously the progression grid for ST4 to ST7. This is the progression grid for the oncology common STEM year. Clearly the levels of entrustment are lower in the oncology common STEM year. For example, with regards to CIP10, working effectively within the tumour-specific MDT, realistically, these are at the end of ST3. We would really be expecting you to observe only. These are the absolute minimum. If you can do more than that, then that's actually great, but that's the level at the end of your ST3 year. The acute oncology takes CIP8 with regards to acute oncology. We felt that by the end of your ST3, and we've had a lot of discussion about this over the past several years, that by the end of your ST3 level, you should be provided to act with indirect stroke minimal supervision, in that your consultant may not necessarily need to be directly beside you. They may be somewhere else in the department. So that's the level that we think that by the end of the ST3 year, you should be able to function at. Most of the rest of them are acting with direct supervision. So next slide, please. So this slide is mainly about acute oncology. So in the curriculum, there's explicit commitment to training, not just through your OCS year, but throughout your training. And that, as with lots of things, as with exposure to radiotherapy, as with exposure to certain systemic chemotherapies, that should be these are levels that can be gained longitudinally throughout your training. We need to prepare you for what's coming in the future. We are going to have to look after more of our patients. The GMC are very keen that we take more to do with our oncology patients. There is a view in lots of the physicianly specialties that we don't do enough about looking after our patients once they become sick. I think that's a lot better than it has been several years ago. And clearly there are lots of things, more things that we can do. So we need to prepare you for what's coming. This development of acute oncology meets the shape of training requirements by supporting acute unscheduled care, so that we are looking after patients who come in acutely, and that we're not contributing perhaps as much as we have been in lots of situations to the work of the general physicians. There is flexibility as to how this is delivered around the country. Clearly there are lots of different ways to deliver this. Lots of centres may be largely nurse-led with consultant input, and that's absolutely fine. That there's clearly a multi-professional team in a wide variety of settings around the country, and the curriculum offers the flexibility to allow the training to be delivered in this full range of different settings. Next slide, please. So it's also important to remember that trainees can be supervised by any member of the acute oncology team. There are lots of situations, as I said, where the acute oncology units may be largely nurse-led, largely often led by senior nurses, with more junior nurses working as part of the team. Clearly they have lots of experience, often more experience than lots of consultants. They are able to assess trainees, provided that they have been appropriately trained for this. This must include structured training with clear educational objectives. There should be the ability to give and receive effective feedback, and the opportunities to develop for development. It is stipulated that your on-call duties alone are not sufficient for, although that may be some acute oncology experience for you, that your acute oncology training needs to be separate on top of that. The curriculum provides guidance on a list of the acute presentations and conditions that the trainee should be able to diagnose and manage. There are separate documents with the curriculum that are on the website. Perhaps we'll come on to that a little bit later, because there's been a lot of changes to the website recently, whereby these lists of conditions that you should be able to manage by the end of your ST3 year, that these lists give you examples as to what these conditions are. There should be the need for in your timetables. There should be ring-fenced time for acute oncology, and as I said earlier, on-call provision on its own is not enough. And the GMC, the curriculum oversight group, the COG group at the GMC, are clearly going to keep a very close eye on this. They've been very clear about this, and if we are not able to demonstrate that to them, then unfortunately there will be other changes, I think, imposed on us. Next slide, please. So the workplace assessments, as I said earlier, there are some new assessments for both specialties. There are new ones for us and the new ones for the medical oncologists as well. We felt that we had to change the program of assessments to match the new curriculum. With the OCS year, the rationalisation of the assessment tools across the two specialties were required, and there's been, again, a lot of discussions backward and forward as to which each specialty wanted to keep and which one we wanted to change and or include in the OCS year. It should be important to note and remember that over the duration of your training, the overall assessment burden has not changed. There is no increase in assessments over the 5 years of your clinical oncology training. and we've been at times very generous that there were many other assessments put in that we managed to reduce, so that the burden has not been increased. So as I said earlier, new for medical and clinical oncology is the acute care assessment tool, which many of you will be familiar with already. The acute oncology scenarios are often very similar to the acute medical setting, where this tool was initially developed. The multiple consultant report has been used again in several medical specialties, and is a good way of capturing the views of several different consultant trainers. And in the OCS year, this should include both one clinical and medical oncology consultant for all trainees. It may include consultants from other specialties and other professions if you work with acute physicians, for example. It can also include consultant radiographers. The DORPs and the DOSTs are new to MO. Surprisingly, the medical oncology did not have our DOSTs, so they have introduced that, which is somewhat surprising, seeing that's all that they actually give. Okay, next slide, please. So this is a table of the overall numbers of workplace assessments required from ST4 to ST7. You'll probably have to take my word for the fact that there is no increase over the duration, because that has been quite carefully mapped out, so that we know that that is the case. Obviously, getting towards ST6, ST7, the numbers of CBDs, DORPs and DOSTs required goes up. Actually, sorry, the DOSTs don't go up, but the clear number of DORPs, and it should be pointed out also that these are the minimum numbers that need to be completed at each year. We're always keen for trainees to do more than is required. The MSF and the MCR are similar, and so we've not required them to be done in the same year. The MCR is requiring the OCS to reflect the clinical and medical oncology input, and at the end of ST6 was felt needed to show greater consultant input at that transition point from ST6 to ST7. It should also be noted that the Oncology Registrars Forum has had a lot of input into this as well. We've had representation on the curriculum committee from the Oncology Registrars Forum chairpersons, also Hannah Tharamalingam, the current vice president, and Nida Pasha have been curriculum fellows, helping develop the curriculum over the past several years as well. So there has been a lot of trainee input into the assessment grid. And I think that's me finished.
Yep,
apologies for my lack of camera.
We've got a couple of poll questions to ask just now. So the first one, just checking whether you're familiar with the ACAT, whether you've used it previously or whether you've never heard of it. So most people are familiar with it and have used it, but there are a few who aren't familiar with that. There will be, I'll come on in a minute to talk about the support that we've got available on the website, and there will be some additional guidance documents on the workplace-based assessments in general, but particularly the new workplace-based assessments that will provide a little bit more information on those for the people that aren't familiar with the ACAT. And then the next poll question, just to find out whether you're familiar with the MCR from previous training. So again, the majority of people have used it in the past, with a few who aren't quite so familiar with it. Okay, so it's back to me then to talk about the implementation timeline. So to begin with, it's worth mentioning that the timeline to a certain extent was dictated by the GMC. It's a GMC requirement that all trainees, including less than full-time trainees and those who are out of programme, have to transfer to a new curriculum within 1 calendar year of the implementation date. Their reasoning behind that is that trainees should be trained to the most recent up-to-date version of the curriculum, and that there's a potential issue with standards if we have a number of years where trainees are being trained to an old curriculum. So the new cohort of ST3 trainees that will be starting in the summer, I think is the next time that they'll be starting. So they'll begin on the new curriculum. Current trainees will transition to the new curriculum for the vast majority of people after their ARCP for the 2020-21 training year, and that includes less than full-time and out-of-programme trainees. So for most people that will be in the summer, but it also allows for trainees who have later ARCPs. So perhaps if your ARCP is in September or November maybe, you will transfer at that point. So you're not changing partway through a training year, you're changing when you're having your ARCP. We've got a range of support available for implementation. And we're putting resources as they're available onto an updated curriculum section of the RCR webpage. There'll be more information on there coming soon, but I was going to take the opportunity just to give you a quick tour of what the webpage looks like. So there's some information at the start here, but the main sections that you'll be looking at are these sections here. So the curriculum itself is under the first tab, and there's the curriculum document itself, but also a mapping document. So the purpose of the mapping document is to help show how the current competencies listed in the current curriculum apply to the CiPs within the new curriculum. So there's no intention that people will need to be going back and retrospectively showing how the activities they've done in previous years provide evidence for the current CiPs. That's all there within that document. So if you have passed your ARCPs and progressed up until this stage, then you will have met the CiPs relevant for your stage of training in the vast majority of cases. If there's any concern about areas that people might have been missing, then the mapping document will help to cross-reference that, so you can identify any areas where there are capabilities missing. The next important section is the section on implementation tools, and most of the guidance for the new curriculum is found in this section. So there's a training slide set, which is very similar to the slides that we've been showing you today. There's a terminology guide. I think Rachel mentioned at the start that there is some new terminology within the new curriculum. So there's a glossary here of each of those terms and what they mean. There's an implementation checklist, which is divided up depending on who needs to be doing things to prepare for implementation. So there's a section for trainees, but also for your supervisors and for ARCP panels to make sure that everyone is prepared for the new curriculum. It's guidance for deaneries and ARCP panels, so they're clear about who they should be assessing against which curriculum at which point in time. And guidance about using the entrustment scales to assess progress. There will be some more resources being added to that page, hopefully very shortly. There's a link to the Kaizen e-portfolio from the curriculum pages as well, and also a page for assessment. So the decision aids can be found on this page. Also, the drugs list for the Part 1 exam is available here, and hopefully by the end of next week, possibly the beginning of the week after, we'll have a full set of exams guidance on here as well, and guidance for the workplace-based assessments, each individual workplace-based assessment, which will also include information about how to access those in Kaizen. There's also a variety of other information, so some key documents and information similar to the information that you find on the found on the old curriculum pages, so resources for less than full-time trainees, links to the ORF. And there's also a section for you to provide feedback, a frequently asked questions section, which we will also be updating based on the questions that we received today. And then if you're looking for previous versions of the curriculum, including the current curriculum, they are all available on this page as well. So in terms of the resources that are coming soon, we will have some short videos on various aspects of the curriculum, and also the recording for this webinar will be available on the implementation tools page as well. We're also going to have curriculum champions. So members of the ORF have been asked to be trainee curriculum champions, and we will also have your regional service advisors, regional specialty advisors acting as trainer curriculum champions. And the idea with the curriculum champions is that they can be a local point of contact if you have questions or any concerns, and to provide information, and also to make sure that any information from the college is communicated effectively as well. They will be letting us know about any regional meetings that are taking place that we can go along to talk to both trainees and trainers about the new curriculum. So if you're aware of any meetings, particularly meetings that might be happening for trainees, and you'd like someone to come along and talk about the curriculum, then you can just talk to your curriculum champion and they can arrange for someone to come along to that meeting. Exam guidance, as I mentioned, and the workplace-based assessment guidance will also be there. And we have already had some trainers contacting us, asking us to speak at meetings for trainers and trainees. So if you speak to your TPD, you should be able to find out whether there's meetings happening locally. And if you ask them and then don't have any meetings, then maybe you can encourage them to arrange those for you. So I'm aware that there's quite a few questions in the question box, so we'll start tackling some of those now.
So there's one that I think I can answer, Louise, while you're looking at the other ones, which was, I think, about, do you need to, and I think you answered it already, do you need to get to entrustment level 4 in everything? And the answer to that is no. And hopefully we highlighted that there are certainly areas where we would not anticipate at the CCT, and that obviously is specialist areas such as brachytherapy, etc. So the answer to that is no, and that reflects the fact that we recognise that some very specialised aspects to clinical oncology are actually learnt and honed as a consultant. So there were a couple about less than full-time training, which I think would be better answered by you, Louise.
Yes, just taking a look at those now. So for all trainees transferring, it will happen after their ARCP, and we recognise that for less than full-time trainees, that their ARCP happening on an annual calendar basis may actually fall part way through a training year. Unfortunately, the GMC requirements are that it has to be, all trainees have to transfer within a calendar year of the implementation date. So there's flexibility within that year. So the official implementation date of the new curriculum is August this year. So trainees would all need to be transferred onto the new curriculum by September 2022. So there is some flexibility about exactly when you transfer. And there's a very small number of individuals who might be affected by late ARCPs. So trainees who are within a calendar year of their CCT date don't need to transfer. However, if your ARCP falls just outside of that year by a few weeks, then we can give some flexibility there so that you're not transferring with a couple of weeks of training left. Just checking, so I think there's a couple of questions on there. So when we were putting the curriculum together, we consulted right the way through with a variety of trainees, and less than full-time trainees and the less than full-time trainee representative on ORF were all included in the consultation process. And we did do a full equality and diversity assessment as well, which was one of the requirements from the GMC when we were submitting the curriculum. So throughout that, there weren't any concerns raised about less than full-time trainees being disadvantaged in that respect compared to the current curriculum. And in fact, the main thing that came across was that the switching to the new curriculum could actually benefit less than full-time trainees because there's less of a focus on time-based education, more focus on achieving those outcomes and people being able to progress earlier or later if they've achieved those outcomes earlier or later.
I have to say I'm struggling to see the questions, I'm afraid, Louise.
Yeah, there's quite a few on there, so I'm trying to scroll through and find the ones that we've got. So I think there's some other ones on less than full-time, but we'll come back to those.
So I think there's something on there about acute oncology as well. I think what I'd say about acute oncology is there are many ways to deliver the acute oncology requirements within the curriculum to meet the CiPs. And I think the thing to emphasize is this is a process that goes throughout your training. So it's really important that we don't think that the acute oncology is something you do that happens in the OCS year and then it's done and dusted. It's not. It's through the process, so that is something you take into your consultant post as well. I draw your attention to the recent publication from the RCR, published in October, I think, of this year, on acute oncology, increasing engagement and visibility in the acute care setting. It's an excellent document, lots of ideas in there, lots of case studies from around the UK of how acute oncology has been implemented. So if that is something that's concerning you, then I definitely draw your attention to that publication. And I'd also say, and I've said this to the trainers, that for the OCS year, it's likely that it will probably take maybe 2 or even 3 intakes into that year to really get that year right, working with medical oncology TPDs and trainers as well. So it's likely that there may be some flexibility in flexing rather and changing of that year as you as trainees and trainers realise that some things that they planned worked, some things didn't. So I don't think you should get too stressed that this has to be perfect from day one. There is flexibility around that, and we understand that this is difficult for you because this is yet again another change, a new curriculum in the context of what's happening at the moment. It just seems too much, but as Louise says, there is flexibility around this, and I think the new curriculum gives you a lot more flexibility and opening in your training. So Louise, have you gathered some more questions during that?
Yes, so there's one question sticking with AOS, asking for a bit more clarification about what's meant by managing the AOS team. And does that include managing the team and liaising with general medicine, or just the acute take?
No, I think managing the acute oncology team is about working with, often these are nurse-led, so or working with whoever's in the team to actually not just manage the acute take, but manage all the acute oncology referrals that come in out with the take. So those are obviously patients that may come in through acute medicine who have a diagnosis of cancer or suspected cancer, and it's about being able to lead in that situation. I don't know whether you want to come in there, Graham, but I would say it's about being able to direct and consider how these patients should be managed, perhaps who should go and review them, those sorts of more higher level decisions that we would expect an ST7 to be making in preparation for being a consultant. So Graham, did you have any?
Yeah, I would agree with that, Rachel. I think it's about making decisions about this person's been sent up, but actually they're fine. Yes, you can go home, and you know, in consultation with the nurse who's done OBS and done bloods, and everything's actually fine, and that person does not need to stay in. Also about the patients who need to be assessed urgently, and so to my point of view, it's a bit more like an acute medical take. except all the patients have got cancer, is who needs escalated quickly and dealt with quickly, who can go home quickly, who has other things that need investigated and perhaps still need to come in, but not as urgently as somebody else who's coming in with a really bad colitis from their immunotherapy, or somebody who's bad neutropenic sepsis. I think the carcinoma on primary is a separate setting. You may get involved with that as you become more senior, but I don't think that's what the acute oncology generic specialty CIP is meant to consider.
And what I just come in and say that I think going round, as I'm doing at the moment, just talking to different training schemes, I think different TPDs and college tutors have got different views about how this might be implemented. And I think it's really important, particularly some of you more senior trainees, that you perhaps find out what the plans are and input into that, because you have that experience. You know, you're often managing acute oncology, and I think it's really useful to have that input as to what you feel is happening on the floor. We really need to hear from you. So you know, I think it's really important that you do talk to your TPDs about this, or your trainers, and if you've got ideas, great, that would be absolutely brilliant. And some of that obviously then reflects thinking about managing the acute oncology. So that would be how that would, you know, that would very nicely fit into that CIP about managing the acute oncology. Where are we now?
So there's another question here. Our current training is already heavy on prescribing and managing SACT to the detriment of radiotherapy training. The new curriculum looks to further exacerbate this problem. How will the curriculum safeguard high quality radiotherapy training?
So I can start on that. Maybe Graham wants to come in there. I'm not convinced that it's any more SACT in there than there was in the previous curriculum. I'm absolutely on board with you with regards to safeguarding, you know, high quality radiotherapy training, and there are clinical oncology specific CIPs which specifically relate to this part of your training. So I think it's really about you know, within your rotation within a tumour site, finding that balance between you know, radiotherapy and chemotherapy. I don't think, as far as I'm aware, there are any more. There's a higher requirement for DOS compared to DORPS compared to the previous ALCP requirements. And in terms of the OCS year, again, there is a balance between both SACT and radiotherapy. And again, talking to trainers, I think there's more of a concern for medical oncology trainees getting experience in radiotherapy rather than the other way around. And there is also a real consciousness by your trainers that we don't want to lose that high quality radiotherapy training right from day one, right from the ST3 year. So I think that's, yes, it's something we definitely need to be aware of, but I don't think there is any additional burden in terms of DOS or CPDs related to SACT. I mean, Graham, perhaps you want to come in there because you were involved in the development of this.
Absolutely. We were very clear that we did not feel that there should be any more systemic treatment as part of any new curriculum, as we're well aware that radiotherapy, even since I started becoming a consultant about 12 years ago, has become way more complicated, often including concurrent treatments also. I mean, I hate to say, but it sounds like that's nothing. What is being described, I don't think can be put on the curriculum. That, unfortunately, is a training issue, and I realise it's maybe the forum for this, but it sounds like that needs to be addressed through your consultant, your education supervisor, clinical supervisors, and TPD. I may be speaking out of turn, but that's. I don't think there's any particular reason for any concerns about increased SACT. Yes, there may be more acute oncology. That's unfortunately combined with a lot of other issues, in that if the medical oncologists don't do this, the GMC COG group and the College of Physicians are somewhat clear that they could be taken back into Group 1 specialties, which we think would be a disaster. So there are lots of other things tied up in this acute oncology STEM year, common STEM year, but the increase in SACT for clinical oncology trainees is not part of that, I think.
If I just jump in for a second, just to add one last thing, in terms of the ARCP decision aids, the workplace-based assessments focusing on SACT, so the DOSTs, there are half as many DOSTs required as DORPs. So the ARCP decision aids are very clearly showing that the focus should be on radiotherapy. And just to agree with Graham, that if you feel that the balance isn't quite right, that's not something that's required within the curriculum. It would be a sort of local training program issue and something for you to raise with your educational supervisor in the first instance, and then your TPD if you feel that there's still an issue.
Sorry, you carry on, Louise.
I was just going to move on to another question unless you've got anything else to add.
No.
Okay, so there's a few questions about the ACATs. So a couple that are focused on the required patient numbers. So one of them saying, with regards to ACATs, if you're in a smaller DGH for part of training, it would be difficult to accrue enough patients for a whole ACAT in a 24-hour take, and what provision is there for this situation? So I'll just start off with that one. So the ACAT has been adapted from the one that you are used to seeing in CMT or in IMT. So the CMT version requires a set number of patients. I think it might be 5 patients that you're seeing in that time period. And we were very clear that there isn't a patient number for this. So it should cover a set time period where you are providing acute oncology care, but it's not a set number of patients. So if you're on a 24-hour take, then the assessment covers that 24-hour take and not the number of patients. Rachel and Graham, I don't know if you've got anything to add to that.
Yeah, I think I would just come in and say we've moved away from numbers and it's about quality. So I think you can learn a huge amount from 1 or 2 patients who were admitted, and that's, you know, that was the whole point, and derive that, because remember, these are formative assessments. These are not, you know, these are as part of the sort of learning and the formation of your assessment. So I think, you know, that it's not a number, and I suppose you know, obviously you won't have seen some of the detail around this, but it is more about the quality of those discussions. And obviously, as you progress through your training, the quality of those discussions will become a lot higher because of your experience and your knowledge. And you know, I find that as you get, you know, into your ST6 and 7, my trainees are telling me what to do, and that's sort of how I would expect that to be. I think that for me, Graham, it's about quality rather than quantity.
I was just going to echo what you said, Rachel. We have again spent long and hard, many meetings fleshing out the numbers, and as you said, you could do 10 DORPs of very poor quality, but if you did one of a very high quality, then the learning points may be much greater from 1 as opposed to 10. We did toy at one stage about not having any minimum requirements, but it was still felt that there should be some minimum placed each year. Clearly, the more the merrier to a certain degree, to get as good a breadth of experience over your training.
There's a few other questions relating to the ACATs, which seem to be mostly focused around the fact that they're quite time consuming to complete. And I just wanted to point out that the required numbers of the ACATs are low. There's only 2 required in the whole of your training, so hopefully it's not increasing that burden too much. And where we have included those, we've tried to reduce numbers of other assessments to try and make that burden a little bit lighter.
Absolutely.
And
and I think, sorry, Caroline.
the questions also looking at whether discussion suffices or whether the consultant supervising and completing the assessment would need to be seeing the patients. So I don't know if you want to address those questions.
Well, I think the whole point about this is a discussion about the management of those patients. In some situations, it might be appropriate for the consultant to see the patient. In some situations, it may not. It may be, that as a discussion is the most appropriate. And I think we are, in this current environment, we're learning that we can do some of this as a discussion. So I don't think it's prescriptive that this has to be that the patient has to go and confirm, a little bit like a check your findings sort of exam situation. That might be something that's more appropriate for trainees who are earlier in their training, and that you would expect a consultant to be doing that. But as you progress and your entrustment basically of your trainees is more secure, then you will, it may be that changes at that time point. But I wasn't aware that there was any, again, definite sort of prescription on that, Graham, from when you've developed these.
No, no, absolutely. But the more you could do face-to-face, and having a consultant see them, but I absolutely agree. I don't think if you've examined somebody and said that they've got crackles at the right base, I don't think I would need to go back and physically examine them. I would have to, as you said, the levels of entrustment reduce or increase as you increase through your training. And so there may be the odd time that you might go and feel somebody's tummy or look at somebody's mouth or something like that, but there has to be a level of trust in these assessments.
I think there's also a comment with regards to these new assessments, as Louise has said, about time. So we're aware that time for trainers is variable and variably recognised by trusts in consultants' job plans, and we're very aware that that is an issue. The college continue to push and make recommendations, and with every new consultant job plan that is developed, it has to be approved. I'm sure you're aware, has to be approved by the RCR. And one of the most important discussions there is around SPA time for consultants to be able to provide training for trainees who are our next consultant colleagues. And it's in our own interest, obviously, to train you to a very high level. So it is something that we continue to push on, and that is why my understanding through France that's why the number of assessments that we are requiring has not changed from the previous curriculum, because clearly that is achievable because people get through their ALCPs with the right amount of assessments. So as Graham says, these are a minimum, they are achievable, but we know that many trainees get many more assessments than the minimal requirement. But it is something that we continue to push and we continue to discuss with trainers.
There's a question. Oh, sorry.
No, you carry on. You're better at spotting these.
So there's a question about avoiding, it talks about the ACAT specifically, but I think it applies to all workplace-based assessments, avoiding the becoming tick box exercises. So I can answer part of that. We are, alongside the curriculum work that we're doing, we're also working with our PLD team to develop the supervisor skills courses that your supervisors are required to attend. And we are looking at improving the feedback that you're given, making sure that they're aware of what's expected in terms of feedback, making sure that they are taking time to discuss the workplace-based assessments with you, that they're doing that in an appropriate setting, so somewhere quiet where you can have a full discussion about things. And the guidance that will be appearing on the website very shortly about each of the workplace-based assessments makes that really clear as well. We're also at the moment working on designing these forms in Kaizen, and we're trying to set them up in such a way that it nudges that behaviour in the right direction, so that the default will be that the assumption is that the form's being filled in with both trainee and trainer present at the same time, so that those conversations can be taking place. I don't know if anyone else wants to add anything to that.
Yeah, I think so, and I think there are opportunities to do that. We're all very busy. I fully appreciate what you're saying, and I suppose it's a case of just being a little bit more aware and nimble and agile about this. So if you're sitting down with your consultant to review a plan, sometimes for example, I might say, well, why don't we do this as adults? Let's get Kaizen up. And while we're going through what we would sit and go through as an educational process, we may as well use that as adults, or similarly, same with a patient where we're prescribing chemotherapy. So there's that planned educational event, and then there's those more semi-planned or kind of opportunistic ways of doing, formalizing what you're doing all the time, so that you can use that as your, as a formative process, but formally recording it on your portfolio. So that, that's the kind of thing that I think is really good practice, as Louise said, sitting down, doing that together.
So there's a couple more questions about acute oncology.
Yes.
So the first one, if you work in a tertiary cancer centre, does that still count as acute oncology? It's not medical take, but those patients would otherwise be admitted to general hospital with oncology input. One thing that I would say there, we have been meeting gradually. We're going through each training programme and meeting with them. And one of the things that we're discussing is what they've got in place for the Oncology Common STEM year and how they're planning on tackling the acute oncology requirements of the curriculum. And each region is coming up with their own solutions based on how acute oncology is within their area. So some of the tertiary cancer centres that we've met with have plans to include, as part of trainees' timetable, time out at peripheral centres. Some are arranging it within. I think, Rachel, you can probably give a bit more detail about some of the examples that we've heard.
Yeah. So some of them will be within a particular rotation. You might spend a day a week with the acute oncology team, where you might go off and see ward referrals. So that would be a very good way of getting acute oncology experience. Some centres are doing blocks of time. So within you might be doing lung cancer, for example, but for 1 or 2 weeks within that 3 or 4 month rotation, you might spend that week with the acute oncology team. Some are doing or including it where we know that in some centres we have a kind of ward registrar system where you're taken out of your normal process, but you're covering the wards, and as part of that ward registrar week, you may also take some responsibility for acute oncology, working with the acute oncology team. For some of the tertiary centres, yes, they are looking at sort of innovative ways where you can get that experience, which may be if you're going out to a peripheral hospital, or what that experience might be for admitting patients into the tertiary centre. So I think people are thinking about it, and they're coming up with lots of sort of interesting ways of ensuring that you do get that experience. Graham, I'm not sure if and as I say, I really would point you to the acute oncology document on the RCR, because it covers lots of these things that I'm saying and gives lots and lots of examples of how people are providing robust acute oncology in a wide variety of settings, and that will give you some examples. Graham, I don't know whether any further examples were discussed.
We as you said earlier, Francis Ewell and Jackie Newby from Medical Oncology has done a lot of work around the new curriculum, but also with the development and the production of the acute oncology document. We were clear that we couldn't really be terribly prescriptive about what the makeup of each region or each centre's acute oncology experience would be, because, as you've just detailed, some of the examples, Rachel, is so different around the country and even between each region sometimes. So, as you said, I think it's important clearly that we're all of a sudden, firstly having this discussion tonight, but that over the next 6-7 months that we continue to have other meetings here, but also regionally as well. We have had a meeting in Glasgow, but by the looks of that first poll, that there's a lot of places that this may be the first formal discussions that trainees have had about acute oncology. So clearly over the next 6-7 months, and I think probably sooner rather than later, those discussions need to start taking place, so that we can all work out what's going to be the best way forward for trainees, so that we can implement this with good outcomes.
I think the other thing that's, for me, that's really important about acute oncology is that if we provide a good acute oncology service, that actually feeds into an easier and better oncology service overall. So I know there's a comment about, you know, are consultants concerned about trainees being taken away to do acute oncology, but acute oncology is still oncology. And if we are seeing patients who are coming in with suspected cancer who are ending up on medical wards, we have the opportunity to intervene at a very early stage and provide that excellent oncology care that we want all those patients to get. So we can advise on whether this patient should be heavily investigated, or they're so sick we're never going to give them any treatment, and therefore they should be referred on to the specialist palliative care team. So there's lots of ways that acute oncology actually improves oncology care for everybody, and I think that's one of the really important messages that has come out for me as I've been more involved with both the curriculum and in parallel trying to improve acute oncology care. So I think we should try and probably think about it in a different way, and you know, there are lots of reasons I think why we should be providing that care to a really high standard.
Yeah. If I could add in, Rachel, if that's okay. Our patients don't like it when they come in under general physicians or surgeons or whatever specialty, because they often feel that no decisions are made whilst those specific doctors are waiting to speak to us, which can take several days at times. And for an all-round better experience for our oncology patients, it should be us who are dealing with these things where we can. So from that point of view, I think that this is very important as well. And yes, you will always have consultants who will mump and moan that you're being taken away to do this, but this is a vital part of your training for the future.
Hello.
So just looking through, there's a question about
there's one.
Sorry, go on, Rachel.
I was just going to say, I found one about radiology, and so there is a CIP on radiology, and I think we use it as an example. Oh no, maybe we didn't, but there is trainees should be able to interpret radiology in order to be able to contour, and I agree that radiology for clinical oncologists is really important as part of their training, but the training, the curriculum gives the flexibility for that to happen, and it is definitely in the curriculum about interpretation of radiology. And I know that this is something that many heads of training are looking at in terms of trying to provide better training, formal radiology training for clinical oncology trainees. So that is within the curriculum in reference to your ability to contour, which is obviously why we're very interested in being able to interpret radiology.
So there's one question that's come up. It says, do you think with the new joint ST3 year that we will lose numbers in clinical oncology? Medical oncology has always been more competitive to get into, and you can imagine trainees wanting med-onc, but getting a number would take a clin-onc number and then plan to switch.
Okay, that's a really interesting question. I'm not sure I would totally agree with the premise that
Me neither.
A lot of people come into clinical oncology but really want to do medical oncology. We are oversubscribed by a long way of people applying to do clinical oncology, with exceptionally high standard of candidates applying, which is borne out by all of you who are all excellent trainees. So I'm not sure I fully agree with the background to that question to begin with. If I'm being really honest with you, I think the number of trainees who will switch between clinical and medical oncology will be quite low personally. We will see. Because if you remember, if you want to switch at the end of that ST3 year, you're not automatically given. So for example, as you've said, if you want to go from clinical oncology into medical oncology, you're not automatically given a medical oncology number. You have to go back through the recruitment process. The advantage of the OCS year is that you will only then have to do 3 years of medical oncology training, or if it was vice versa, you would only need to do 4 years of clinical oncology training, because that first year would count. And that is the flexibility that the GMC required. But I think we have, certainly from interviewing in the last couple of years, well, certainly the last year, it was clear to me that majority of trainees who'd applied for clinical oncology wanted to do clinical oncology. So Graham, I don't know what your thoughts are on that.
Yeah, I've also pointed out at various meetings that I think the overall numbers of trainees who will switch will be low. There is the ability to do that just now, not to count the whole year, but clearly there's the ability to switch just now, and the numbers that do that are low. The GMC simply wanted there to be greater flexibility in all training scenarios, actually. I also agree that the applicants for training in clinical oncology and national recruitment are at a very high level. We know that we have very good trainees, very highly qualified trainees, very motivated trainees, many of whom have done special study modules, taster weeks, etc., in clinical oncology. So I think the numbers of trainees who enter into this not being sure what they want to do, I think are low. And again, I think the numbers that will switch will be low, but we'll have to see how that goes.
And I think the other thing to reassure you is that the numbers between different specialties, how you obtain different specialties, is not just well, first of all, it's extremely difficult, which is why we continually lobby and try to increase the numbers of trainees so that we can increase the number of consultants, because we know there is a shortage. But it's not as simple as just switching a number from clinical to medical oncology. It doesn't actually work like that. So I have absolutely no concerns about that. I do think that what I do hope is that the OCS year will mean that clinical and medical oncologists, as you grow into consultants will have a much better understanding of each other's specialties, and which will only be better for cancer care, that we will work as a much more unified specialty. And the reason that I really hope for that is because the more of us that are in oncology and are agitating at a national, government and international level, is the more likely we are to achieve things that we want to achieve for our patients, such as overall increase in the number of the workforce overall. So for me, that's a really important part of the OCS year, about that working together and just strengthening oncology in general, because the bigger our voice is, the more likely we are to get heard across the piece.
There was I think the first part of that was perhaps about overall numbers, and as I think you've said, and in my experience with the college over the past 6 or 7 years, is that at each specialist training board meeting and any other meeting I've been involved with, there is a push from vice president level for more trainees at each meeting I've been at. There has been no suggestion that numbers would decrease. Clearly, cancer is becoming more prevalent, treatments are becoming more complex, we have many more treatments, and we are only going to continue to have more with an aging population. There's always going to be need for more oncologists, so if anything, the numbers will continue to go up over the next several years.
I think we're coming to an end now, because it's 7:30, and I'm really grateful to all of you for giving up your time, and the majority of you stayed till the bitter end. We've answered some questions that we answered and you weren't happy with our answers, so we've re-answered them. I just want to say something about acute oncology, and I think there is emphasis on acute oncology, and that was because we had to do that in relation to the GMC. So some of that was forced on us. Some of it is because we think it's appropriate for the reasons that Graham and I have highlighted, but some of it is because it's new. And so therefore, it's important that that is delivered well. And so I think that's why acute oncology has been talked about a lot. And it's something that trainers may have to rearrange some aspects of training in order to be able to deliver in line with the curriculum. So I don't want you to go away tonight feeling that the most important part about this curriculum is acute oncology. It isn't. It is just part of the curriculum, but it is new and it will require some thought and rearrangement. We're fully on board with you that that is just part of your training, and it is of equal importance, as we've tried to highlight, Graham and myself, as your ability to be able to deliver SABR, or your ability to be able to deliver complex IMRT for a patient with rectal cancer, for example. So I think it's really important that we get this all in balance and in context. And I think that's to some extent why acute oncology has been emphasised, as I say, because it is new to us. And I think we shouldn't panic or get agitated about this. I think we will settle into this. And as I say, it may take 1 or 2 iterations of rotations and trials for your trainers to get this right. And that's where your input will be very valuable as well. Graham, did you want to Graham or Louise, did you want to make any sort of closing remarks?
We've done a lot of agreeing tonight, Rachel, but we've clearly focused on the OCS here because that is the new thing, but we are also still extremely interested in training you in advanced radiotherapy techniques, in good palliative radiotherapy techniques as well, in systemic treatments, in concurrent treatments, in new systemic treatments also. It's just that this is the new part of it, but the radiotherapy and good high quality radiotherapy treatments is extremely high on our agendas as well. It's just that this is the new thing that's come through that unfortunately has to be addressed, because as I said earlier, if it's not addressed, the COG group will come back to us, and there were veiled threats over the years as to what would happen if this wasn't implemented, and as I said, medical
And I think
oncology.
just to intervene, Graham, then we would have real concerns about the impact on your training. I think that's
Absolutely.
the real point to emphasise there.
Again,
Louise, did you want to
So
say
just
anything?
a couple of quick things for me. Firstly, obviously there are some questions that we didn't quite get on to answering. We will be updating the frequently asked questions page on the website, but also there were a few questions in the question box that were about quite specific individual circumstances. The questions do show up with your contact details, so I can get in contact with those people who were asking about specific situations and get an answer to them about their personal situation. And then just finally to say that any further feedback can be directed to our curriculum mailbox, which is curriculum@rcr.ac.uk. And if you've got any further questions at another point, then they can be addressed through there, or you can speak to your TPD or your curriculum champions. The lists of curriculum champions will be on the website shortly.
Excellent, thank you. And as Louise said earlier on, I would encourage you to go back to your TPDs and suggest that they ask us to come and talk to your trainers as well. So I think that's really, really important. This is a whole department implementation. It's not just the TPD and trainees implementing this. So finally, the last poll, how prepared do you feel now? So please rate yourself below.
Okay, just give it a second for the responses.
Okay, so pretty much in the middle, which I think is excellent. Actually, I'm very impressed as always with our trainees. Always impressed. So I think that's really, really encouraging. And I think if you're not prepared, obviously there's a lot on the website to help you. And please be in touch. We're here for you. In particular, I'm here for you. I was elected to, as I say, help with your training, to manage your training, to be your lead for training across the UK. And I'm very happy to be contacted directly through the RCR, and I will try and respond in person to anyone who does. So at that, I'm going to leave you on this Thursday evening. It's snowing very heavily here in Leeds, so I'm a little bit skeptical about being able to get home now. So, but hopefully I will be able to. So thank you very much. Thank you also to Graham and Anna in the background for all your help and support. And as I said, please be in touch if you've got any concerns, ideas, thoughts, feedback. And as I also said, I'm very happy to speak to any trainee personally as well. So with that, I will say good evening.